Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Jacqui people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Well, welcome back, everyone, to another episode of Research Works. It's that time of the week again, a new topic, a new wonderful guest, and also welcome back, Marissa. Thanks for being here again, Marissa.
Thanks for having me. You know I always love being here, always.
It is always nice to have you join us. So Ash has taken just a quick break, but it's really lovely to be able to have another clinician to be able to interview our wonderful guest today, Dr. Jacqui Barfoot. Thank you so much for joining us. Hello, Jacqui.
Hi, Dana. Hi, Marissa. Thank you for having me today.
Oh, it's so nice to have you join us. And we are in a slightly different time zone, but, you know, through the power of some scheduling and online platforms, we can make this work. And we're very excited to talk to you about this topic today. And I think when we first reached out and we were talking about some of the work you've been doing, I was immediately really interested. And I know that the listeners are going to really lap this one up too. That the article we're going to be really focusing on today was published in the Journal of Occupational Therapy, Schools and Early Intervention in 2023, and it is titled Including a Relationship Focus in Pediatric Occupational Therapy Interventions, Introducing the PAIR Model.
I'm really looking forward to this conversation as a clinician and as a parent. But for our listeners, before we jump into that, I think it's important we tell them a little bit more about Jacqui.
Indeed.
Jacqui is an experienced pediatric therapist and researcher. She is committed to creating a shift in early childhood therapies where parents are at the centre and rich parent-child relationships are sustained and strengthened to help optimise child development. Jacqui works in a number of roles. These include postdoctoral research fellow with the University of Queensland, reflective supervision for practising early childhood therapists, occupational therapy for children with developmental difficulties. This is amazing, by the way, and training and consulting for therapists and organisations, including the Benevolent Society in Brisbane. Jacqui.
Yeah.
Wow.
Goodness me. I love it. It's obviously very accomplished, using your time very efficiently. But I think what I love so much is the clinical research aspect. And that's not an easy thing to do both things, right? So, you know, congratulations on all of that. And
It's happened probably by accident more so than by plan.
It often does, I find. You kind of just, when you tell people the story, it's usually like I stumbled into these things and here I find myself. But it's wonderful. And I think that is what makes your research really relevant. And yeah, we'll go more into that. But of course,
icebreaker question.
We do have one, yes.
Okay, Jacqui. I'll give you a moment to think about it, but what is your favourite go-to meal that you cook for yourself or your family at home?
So I'm going to be completely honest. I don't cook much at home. Maybe that's how I achieve all of those different pieces in my life puzzle of work. My husband is a very good cook and my children much prefer his cooking to mine. So my go-to meal is usually something that he's cooked. He does a fantastic spaghetti bolognese and also a fantastic Thai curry. I can't lie. If I try to do the spaghetti bolognese, which would be the meal that I would cook if I'm forced to, it never tastes as good as his.
It's amazing because once you have that reference point, isn't it? It's hard to compare and it's hard to compete.
I stick to my strengths.
That's all right. I think that's a good line.
It's actually a really good, and everything we talk about in research now is a strengths based approach. So we can apply in so many different circumstances. And it's true. Let's just highlight the things we're good at and highlight the things others are really good at. I like it. I love the honesty. So, okay. So I do love cooking. I really do enjoy it. I do much rather going out and having someone cook for me, but a budget doesn't really allow for that every single meal. So mine is always a stir fry. After I learned how to make a stir fry, which when I first moved out of home, I realized was actually not that easy. I put way too much in a pan. It was all watery. And I thought, all right, just being Asian doesn't mean I can make a stir fry. It's not a natural thing. You actually have to learn. So I love that you just need like some protein and you have some veggie. And my standard sauce, which I'm going to share with everyone, is a bowl with oyster sauce in it, a little bit of sugar or honey, rice wine vinegar, sesame oil, a little bit of rice flour, a bit of water and sesame oil. You mush that all, you just stir it all up. And once you've stir fried all your meat and your veggies in there, you pour that over it. And it is fantastic. It is a great go-to veggies, protein over a bed of white jasmine rice. I'm not going to go for brown rice. I'm going to go for white jasmine rice because I love the starchy content of it and it's much better.
That sounds amazing.
It's great.
Yum.
It's my go-to. Yeah. What's your go-to?
That's a good go-to. Mine is eggs. So my kids luckily like eggs, and so we joke that Thursday night is egg surprise night. So the surprise element being, how will you have your eggs? Will they be eggs and soldiers, scrambled, not poached? I haven't mastered that. Omelette or fried. So we joke that is... And I think it's in the marketing approach because the kids are quite excited about egg surprise night.
You sold it well. Egg surprise.
Yeah. I can do eggs.
That's do you know what? That's me too. I play to my strengths. Well. Yeah.
I love that.
And I'm also very good with cheese and crackers.
Cheese and crackers as a meal is completely fine. There is nothing wrong with that, right? We do talk about food a lot on this podcast, and that does make me quite hungry. But that is not the purpose of people tuning in for this podcast. Let's get into the fabulous work of Jacqui. So a bit of a rundown what we'll be talking about today. The importance of parent-child relationships for child development outcomes suggests a need to incorporate a relationship focus into early intervention programs for children with developmental delays. Yet there is some confusion around the definition and application of relationship-focused interventions, as many occupational therapists remain more developmentally and child-focused. So this report provides a new conceptual model called the phased approach to incorporating a relationship focus, or PAIR, P-A-I-R, that can be used in pediatric clinical settings. Meaty.
Okay, so we're going to start at the very start. Jacqui, let's start by talking about the parent-child relationship. Why is it so important, and what made you kind of go down this path in your research?
So as a new graduate, I was working with families who had children with very significant disabilities, actually. And the way that I was trained at university was that I would think about where this little one was up to developmentally, and then provide activities to help strengthen those areas of concern or of difficulty. And so what that usually entailed was me sitting with the child and leading both the tasks, but also leading the session while the parent kind of was on the side watching. And then at the end, I would talk about, potentially things that they could be trying at home. In the context of what these families were experiencing, I really wondered about the effect that I was having for both the child and the parent. And it kind of didn't sit well with me that was how I was working. Sure. And from there, I moved to a team in South Australia and I was working with children with much more kind of mild developmental delays or concerns. And this team used a relationship-focused approach. We didn't call it that then. Sure. They were using something called the circle of security approach, which is based on attachment theory. And what we did there was we helped, we sat alongside parents and we got parents to play with their child, and we would use video and watch the video back with a parent and say, what do you think your child is telling you right now, or what do you think they're needing right now?
Yeah.
And how could you join what your child's doing right now? So it was lots of problem solving with parents around how a child was giving signals and how the parent could respond.
Yeah.
And what I noticed as a therapist was that children made gains really quickly when we worked in this way, acknowledging that they were children with more mild difficulties to start with than the little ones I'd been working with previously, but also that parents said that they felt like their confidence with their children increased, and that they felt like they then knew what to do at home in trickier moments or getting out the door, and that they didn't feel like they needed to keep coming back to us because they'd built this repertoire themselves.
Yes.
So that really spoke to me, and I was really fortunate to work in a very experienced team at that point, so I got to really build my skills in working that way. And then I went to Darwin, and I was managing a team then actually again with families who had children with much more significant disability again.
Sure.
And I wondered, would this approach fit when a child has more significant developmental needs?
Yeah.
And there are a suite of programs that are already available that we can use as clinicians, and you might be aware of some of them, the Hannon programs, DIR floor time, the Denver model, that they are relationship-based or relationship-focused approaches. But what I was struck by was that as a therapist, it's often very hard. What do I do in the moment with a family, and how do I meet the needs of a particular family if I'm wanting to work in this way?
Sure.
And it's often about our confidence working in this way that makes a real difference. Also, what is the evidence for children? Like there's a lot more probably for autistic children in terms of relationship-focused approaches and some of those programs I mentioned. But I was interested in what about little ones with cerebral palsy or little ones with intellectual disability?
Yeah.
Is this still a good fit for those families?
Yeah.
So I applied for a Churchill Fellowship, and I travelled the world visiting researchers and therapy centres who were working in that way with a broad range of children with significant needs. And what I was struck by was that there's a lot of evidence to inform this way of working, but there's not a lot of, targeted research that's been done with these populations and measured the effects of it.
Yeah.
And at that point, we were really kind of just starting in our understanding of whether this was a good fit for children with significant developmental difficulties.
Yeah.
So those researchers said to me, why don't you do your PhD in this area and think about how we help therapists include a focus on parent-child interactions with these populations. So that was how I landed after being a clinician for many years in the research world.
Yeah. That's incredible. It's nice to hear the evolution of how you went from one thing to the other, which is often how great research comes about, right? It's asking that question, or firstly, not being satisfied with what you're seeing and being okay and willing to challenge how you're thinking, as well as how your industry might be thinking about it and what the deficits, what the gaps are. I really love that.
Okay, and what we might do is just before we jump into it a bit more, is just cover some of the other definitions in the article.
Yeah.
So how are positive parent-child interactions defined?
Yeah, it's a really good question. And I guess when we're thinking about positive parent-child interactions, it's important that we think about the individual child or family and what's a good fit for that particular relationship. So that requires us to tune in to a little one's signals and respond kind of moment to moment. So positive parent-child interactions or are around being able to tune in to an individual signal, think about what a child is communicating through that signal and how we respond. So at times that might look like delight or warmth. At other times it might be putting a boundary in place or taking charge so that the child knows that what they're doing is not safe or not okay.
Sure.
So that positive interaction kind of changes moment to moment, but I guess the biggest element of it is that attunement. So we're tuning in, we're being sensitive to the unique cues and signals, and then we're responding to the need.
Yeah.
Does that make sense?
That makes perfect sense. And kind of brings me to my next question, because you're talking about being in tune with the parent. And then what is parental sensitivity?
Yeah. So parent sensitivity is that ability to read the little one's cues and to be able to respond appropriately or to the need that the child has. And it sounds really easy, but in some contexts, it's actually incredibly difficult. If a child is giving cues that are less salient or less frequent, or if their way of organising their brain and their body means that the cues actually are very hard to interpret, it can be incredibly difficult to read that cue and to know how to respond to it, or to know what the child is trying to communicate with that cue.
Absolutely. And if the parent is, like, depending what situation, like you said, each family isn't attuning to that, because if the parent is extremely tired and they've had a lot of medical appointments and other stress, then their parental sensitivity might be impacted. And so as a clinician, you've got to read that each session. And it's a really important point for us to, we jump into sessions with kids on a day-to-day basis, but there's a lot going on for parents. And obviously they know their child best, but there are things that impact on how they can respond to them as well.
Yeah.
Oh, totally. For all of us.
Yeah.
If whenever we're stressed, it's much harder for us to slow down and tune in to the needs of another person, because we're often, much more caught up in our own worries or our own heads in those moments. Yeah.
And as you're going through those definitions, I always think operational definitions are really important before moving forward into anything. And I think that's where the initial confusion can often be. And it doesn't take much from there to, as you've defined it, to kind of go, okay, I can kind of see the role that a therapist and a clinician might have in that situation, because you're talking about, it's a skill, isn't it? Being really tuned in with your particular child with their individual needs. I love in your paper that you talk about, the occupational therapist, which is, we work with brilliant occupational therapists. So as physiotherapists, we love working together. And I love how you were starting to tease out about the difference between really child-focused approaches and developmentally oriented approaches. In fact, the quotation I really liked was, interventions are built solely on developmental theory, have minimal effects on motor outcomes. And things like that just really hone in on sort of what is our view and perspective as we approach our sessions and working with families. But can you help us tease that out just a little bit more about what's the difference between child-focused and developmentally oriented?
Yeah, sure. So I like to start that with thinking about how a child's brain works, or how our brains work too. It's, I guess, that when we think about children, they're in that a phase of rapid development, and that a child's brain is more lit up when they've initiated the motor cue or the or the play idea themselves.
Yes.
And so when and this is certainly the way that I was trained, and for many of us, potentially we're still training the early childhood therapists like this, that we look at how a child is going developmentally, and we kind of think about what are the activities that are going to strengthen a child's skills or some of those developmental needs that they have. And so we come up with the ideas to meet that. I want to say that comes from a place of good intention.
Absolutely, yes.
And that if we keep in mind that this thing of the brain is more lit up when it's the child's idea or the child's initiation, it becomes a much more effective place for us to work from as therapists.
Yes.
So we're having to kind of resolve that tension around, eek, I want to be the one doing it and bringing the ideas, and actually trusting that if we create a space where the child can initiate and explore, then we can actually have more effects, because their brain is more lit up and their wiring is going to be much more effective and efficient.
Yeah.
So I guess when we use like that theories that are solely motor theory, that tends to be that we will come in with an adult-directed activity to help strengthen a particular skill, versus when we are child-led, and we provide that space, or we think about how to set up the environment so that it's easier for the child to initiate their motor signal or their play idea. And then the child, it feels good. Then they're like, oh, I'm motivated. They're more likely to do more of that.
Yeah.
And development kind of kicks in a really lovely way.
Yeah. Gosh, everything you say there, we are big fans of, and that's where the evidence is all pointing. You know, there's across all different diagnoses and across just development in general, we know that that's really important, and the evidence is really consistent about that now. And I love that you've covered that, because it's a really important basis to start from. Yeah.
It defines our role, and it's kind of changing our role, isn't it? Because you're all about setting them up to have those opportunities and to win, rather than leading it, and which we may have done sometimes because we wanted to get as much as we can from the session. But really, like you said, to light it up and to get the carryover, you're setting the child up. And that's, I guess, the child focused.
And also, if something feels good, we're more likely to do it again. And the more practice we have, the more mastery we achieve. And for children with developmental difficulties, there is that risk that if we do too much, or it doesn't feel good when I initiate, that they lose that opportunity to have those opportunities to practice. And we know that this population is more at risk of becoming more passive in their environment as they get older. And so what we do kind of early on is really important in terms of helping a little one have that sense of, this feels good, I want to do more of that.
And as you say that, I'm just really struck by the fact that it needs to be so consistent across so many different environments. You know, we often would see children who would be, you know, exactly like you said, very child initiated. It's definitely our approach. We want them to feel empowered and to explore. But then if they spend some other time during the week with some people who probably want to initiate more of it themselves as clinicians, the child is quite confused at that point of like, well, do I do it or do I wait for someone to do it? And it's those messages aren't then consistent, because we all know it's about the environment, and it's about not just one session, it's about the day, the week, the month. So that for me really confirms that, doesn't it?
Absolutely. Now, in your paper, getting deeper into it now, you cover some well-known theories, such as the attachment theory. I would love you to just share a bit more about this. I know it's a massive topic and there's a lot of talk about it, even reading your paper, obviously, but can you just go into this a bit more for us?
Yeah, sure. And, you know, I think sometimes developmentally trained therapists, we're at a point potentially for some of us where we roll our eyes when someone mentions attachment theory, because it's been at times misunderstood or misused in other forms of media, or like I think for some of us we can kind of ask, well, what aspects of attachment theory are important for my role as an OT or as a physio or a speechie? And so I like to think about attachment theory is this biological priming that goes on between a child and a caregiver to be in relationship, because the child's survival actually depends on that when they're very little. So for a child who's not able to feed themselves yet, or have those basic care tasks themselves yet, like if we think about, you know, back when we were living in caves, that it was really important that the child was able to signal to the parent, and that the parent or caregiver responded to that signal, because that's how little ones survived. So I think it's really important to acknowledge that there's two people in the relationship, and that the skills and strengths of both person need to be considered in that relationship, and that also because this is a biological priming, sometimes things can can disrupt that. We know that multi-generational trauma can interrupt some of that priming, and also situational things, medical trauma can sometimes interrupt that biological priming. And if we think about how do we get that back on track, it will naturally, children are naturally wired to seek security and to seek, things from their caregiver. And I think what we need to be really careful of in this area is that often as therapists, we are very attuned and sensitive in our nature and our training, and we can inadvertently limit the opportunities for the parent and the child to get things back on track if we take too big a role in the session, because a child will then look to us as the attuned, warm person in the room, and what that potentially feels like for the parent who may be finding it harder to read their little one's cues or respond to them.
Yeah. Oh, so many things come up for that one with me, and I'm sure for you as well, Marissa. When you're talking about that, I think about the role of a caregiver and the child, and that parent-child relationship, which is one of, like he's described before, it's one of warmth and it's one of sensitivity. And I can just imagine that if a child is very distressed, for example, if they're in a medical appointment or a therapy appointment and they're very distressed, we do talk a lot about not pushing forward with that and not allowing the parent to step in to comfort their child, because their child is actually seeking their support to read that cue in a way, isn't it? Like, I think that having the definition of us as clinicians of what it is that we do, but the parents being the parents or the caregivers to provide that warmth and reading their cues consistently, I think is a really important point.
Yeah, and I think you're touching on also there, when a child is distressed, how much are they actually learning in that moment
100%.
And what are they learning in that moment? Because once we've got to that distress point in a therapy session, generally the body's more tense. The child, some of the things that we might actually be aiming for in terms of either motor development or play or whatever it is that our goal is with the family. When feelings are up, we're not actually able to meet those goals or kind of work towards them. We need to help support the feelings first so that learning can come back online. And some of our approaches and some of the ways that we were trained historically, we were told to discount some of children's feelings or not pay as much attention to that and push on through. But at what cost for both the child and also for the parent when we override potentially some of what they're primed to do with their little one.
The term no pain, no gain is not relevant here. And I love how you said that it has to be the first thing to get on track is that emotional and address that first, not the task that we have on our list of things we need to do. That's secondary, and that's a really good message.
I love how you described attachment theory, and I just wanted to jump to a number of children that we see, whether it's due to unfortunate complex birth histories and other, from a young age, a lot of medical conditions and things going on that may have an impact on that. The ideal, I guess, attachment building. And you meant that you can then get to a point and kind of refocus and try and rebuild this. So sometimes as community therapists, that might be when we're starting to see a family, they're having this they're starting to stabilise their medical condition, they're starting to access community services. What type of things can a parent or even a clinician can we do to help rebuild that attachment, aligning with the attachment theory, if it's a few years down the track?
So I guess wherever we're able to slow down and read a little one's cues and respond, we're giving the child the message that I'm here, I see you, your signal is important, and I'm going to respond to that need. So after, like you said, once things are settled and that's an easier space potentially for a family to engage in a service and we're able to do that, we're giving the child the message that we can strengthen the trust in the relationship, that I'm going to take the time to try and understand your cue and respond to that. And because that feels good whenever we're able to do that, it's quite motivating for the child to do that again. So it kind of starts to build on itself. And we don't need to be doing it 24/7. It's what the research indicates is that it's when there's moments of it, they can naturally kind of snowball for both the parent and the child, because for the parent who then feels more confident reading the cues from the practice they've had potentially in a session with their therapist, then next time they're like, that means that my little one's had enough. So I now know that when we're at home as well, or when we're in this context. And so initially it might feel like we're really kind of practicing some of these things, but over time it becomes much more inbuilt, I guess, into the way of interacting.
Yeah. So from there, then, you do touch on that in your paper too, which is actually really, we hear this term a lot, emotional regulation, and that forms part of, I suppose, the attachment theory is supporting the child for regulating their own emotions. But then what happens when they're not so regulated, and what does that look like? First of all, let's just talk about what emotional regulation is. I feel like that as a definition is probably very helpful. Can you help us with that?
Yeah, sure. Yeah. So I think of emotional regulation as being aware of what our body's telling us about how we're feeling, and then knowing what to do with that. So there are some adults or some moments as adults still that we can find that difficult too. So that ability to be like, oh, this is anger, and this is what I need right now to help myself go through that anger or manage that anger so that I can return to that calm, alert state again. And for children, the way that their brains develop, they don't have that ability from birth to recognise a feeling and to know what to do with that, because that requires pathways between, I guess, the back of our brain and the front of our brain that are still developing.
Right. And I guess from there, for want of a better word, things that we do tend to see are these tantrums, as children do develop. And, I would have to admit, when you do see a child in a, very colloquial, full-blown tantrum, what do you do at that point? And I feel like, you can read the cues. Maybe we've missed cues along the way that were going to lead to that, or what do we do in that moment to help children feel that they are secure, but it's, physical as well. There's a lot of things happening. How would you describe our role in that situation when we see that happening? If it happens in a therapy session or happens in a shopping centre, I would tell stories about that all the time. What does that look like, and what do we do?
Yeah, and I guess the first thing is to not take it personally. I think as a newer therapist, I would potentially slip into this thing of I've done something wrong in my session if a child is then having a meltdown, or and to kind of shift into this thinking of for young children, this is part of what happens. They will flip very quickly between that, like the limbic system will fire fast, and it might be over something that for us as an adult, we can tolerate that. But for a child who's very egocentric, they're not going to tolerate that. And the shoot to the that shutdown that happens with the thinking is quick, and often makes absolutely no sense to an adult who has the thinking part of their brain much more switched on. So I think really kind of thinking about our own expectations of children, and understanding typical development with emotional regulation, that we're not expecting any emotional, like kind of self-regulation until a little one's at least 3. Between 2 and 3, some of those things start to come on board, but children will still need some co-regulation until they're between 6 and 9, depending on the child. And that's typical development. So I think sometimes, and as a parent, I can relate to this as well, that we have expectations that our children will be able to manage a lot more than they can, or tolerate them, a lot more. Because we're coming at it from our adult brain, and then it feels very personal when that child does have a big meltdown. And that's often not the most helpful place to respond from. And it's very natural that we respond from that place.
Because I guess that can become very frustrating then, and that sets off another cycle of the need to maybe regulate yourself a little bit as it's all happening too. So it's, like you said, it's 2 people, or at least 2 people that are involved in this. So I guess from a in your paper, you do talk about how, attachment theory and emotional regulation, how that affects development. It makes a whole lot of sense now as you've teased all of them out, because we're really trying to create, I guess, the most optimal environment for children to grow and explore and be themselves, and that's a really important component of it. And I guess that sort of leads really nicely into your model, which I really want to make sure we spend enough time going through. So maybe let's go through, there's a few different phases in it. Should we just go through and define the phases, and we can talk about maybe some examples of how they can be put into play? Because I think it's very interesting how you've developed it.
Yeah, no worries. And sorry, before we do that, I just want to highlight that I'm not talking about perfect environments or perfect interactions, or an environment that is optimal all the time, because that's not the real world, and actually it's not ideal for children when it's always ideal. Like when things are a bit trickier in interactions or in the environment, it actually helps build skills around how we manage with that too. And I think as therapists, sometimes we can feel pressure to have everything quite optimal as well. So that's just, so if we're thinking about incorporating a relationship-focused approach and using the pair model, I just want to say for all of the therapists, this isn't about being the perfect therapist, and it's not that we're asking parents to be the perfect parent or for children to give the perfect cues either.
Yeah, of course. And on that, so Jacqui, just to expand on that a little bit, I think the pressures sometimes are often on there because everything is very activity-based model. It's like, it's the 1 hour or the 2 hours, and this is what I've got. This is the time we've budgeted for this, and we need to make the most out of this. And so there might be a lot of pressure to move on far earlier, far sooner than the child might be ready, and that can jeopardize, ongoing relationships later on. So it's a good point that you make,
And I think what I come back to as a therapist when I'm feeling that pressure is I often think if a family was able to do this already, they would be. And the fact that they're needing some more support or a space where we can slow things down or make it simpler or easier to engage, that there is so much value in that, because without that as a foundation, it is very hard to do all of these other developmental tasks. So because you're spot on. Often it comes down to how we see our role as therapists, and that we need to provide this beautiful session that meets all of these boxes. But so that thing of if the child and the parent were able to do this already, they potentially would be. And what I'm doing is helping create an environment where they can practice the things that at the moment are feeling a bit more difficult, and that there is value in that.
Yeah, that's right. Yep. No, good point.
So I've taken us on a tangent. I'll now
we'll go back to pair.
And I guess to highlight that if we're going to use a model such as a pair and work relationally, this self-reflection of what comes up for us as therapists is part of working relationally. And that for those of us who work in this way, access to reflective supervision is really important, because it creates a space that we can talk about some of those things that have come up today around expectation and how I respond to that as a therapist and what I bring to the mix as well.
That's great.
So that's, I guess, the caveat for moving into a model such as this. And if I think about this model, the starting point is always, does a family need support with parent-child interactions? And to help us understand that as therapists, that first phase is around how we gather information around the parent-child relationship and around the history of the child, but also the history of the family or them together. And some of that is asking questions about, how was the delivery for you, and did you get to connect with your baby after they were born? And I find that commonly the little ones that I work with, there has been birth trauma, medical trauma, and that for some families can stay with them as they move through to the other kind of stages of their relationship. So if a parent isn't supported well with what happened at the delivery, or that they didn't get to hold their baby and they've still got a lot of sadness or guilt about that. Yeah. That's the starting point often in terms of their relationship, or pregnancy is actually when the relationship starts. But it's just, so as a clinician, it's really important that we're asking questions to help us understand when things may have got more difficult for the family. Yeah. Was it in the delivery? Was it when the child was very uncomfortable physically and so was unsettled and dysregulated all the time as an infant? And mum and dad were like, we feel incompetent as parents because we can't work out what this little one needs right now. Yeah. So and it's not around changing the way we do case histories necessarily. It's often just about tweaking the questions so that we include a focus on interactions or relationship as part of our case history.
Yeah. I love that because that's all very... One, it's highlighting an area that, many of us would never have thought of before, I have to admit. Mm-hmm. And it's, that first initial assessment part when you're first meeting, that's what you would do anyway. You'll be asking questions, but this is just having that different lens on, isn't it? And just it's not a hard thing for us to add that into the conversation.
Yeah. I value so much about, because I do a lot of initial assessments as a clinician, and obviously you're trying to know the family and the history, but I love how you bring it to the child and parent relationship. Because as a therapist, whether it's an OT or a physio, if we're aware of that relationship and how we can empower that, whether it's learning, like you said, regulation skills or a motor skill, we're more likely to get success and development in that in a home setting and an everyday setting. And so I love how you draw that in an assessment.
That's beautiful.
And that will definitely be something I definitely take is looking at the parent-child relationship and, what may have impacted things, but also then it keeps in our mind, as you may start management and therapy, how we can promote that and establish, empower that relationship.
That's brilliant.
Yeah. And I've got a family in mind, a little one who ended up receiving a diagnosis of cerebral palsy, and the question I asked her mum was, how would you have described your daughter as a baby? And she used the words difficult. She was very unsettled. And then when I said, and what words come to mind when you describe your relationship with your daughter as a baby? She said, it was awful. It wasn't what I expected. It was just really distressing. Wow. So sometimes those questions give us little windows into what a family's been navigating. And for this family, it was really apparent that some of those things had started really early and was this little one, her body wasn't moving in the way that she was wanting it to or expecting it to, and she was really frustrated a lot of the time. Yeah. So we could then see how that trajectory had carried out, and she was about 18 months old when we met her, and that relationship was hugely stressed and under a lot of pressure by the point that we met them.
Yeah. Wow. Gosh, that makes a whole lot of sense. And I guess that moves in nicely to your next phase, which is relationship-focused sessions. Please talk to us more about that. Very interesting.
Yeah. So as part of that first phase, I encourage therapists to also observe the parents and the child playing in that initial appointment. And there's a couple of different ways that I might do that. I might, when the session starts, say, play with your child as you normally would, because we're new people in the room or in your house, and they're not going to feel as safe and confident with us. Yeah. So for them to play with you and know that we're okay in this session is helpful. Also, or I might do it towards the end of the session, and I say, it's really helpful for me to understand how your child gives you cues. Are you happy to play with your child for a few minutes just so that I can see how they initiate play ideas or motor attempts?
That's beautiful. Yeah.
So the focus is really, I'm not saying I'm looking at the relationship for the purpose of judging or analysing the relationship. It's to help understand how a little one gives cues and how hard or easy it is to respond to those. Yeah. And so once I've got that, the case history, and if possible, that and it only has to be a couple of minutes. It doesn't need to be a big part of the session. That can really inform whether a relationship-focused approach is needed in that second phase. So for most of the families I work with, that couple of minutes of play is actually really tricky. And it might be that the little one isn't giving many cues, or the cues are very difficult to read, and it's got off track. So when I see that in the first session, I can talk about that with the family and even say, depending on my relationship with the parent and how that session's gone, I might say, this time, let's do a couple of minutes where you wait and see what your little one does, and then put words to that or respond to that. And then then they do that, and I say, what did you notice between play 1 and play 2? And a parent will often say, gosh, in play 2, they did so much more. They were happier. They were more engaged. And then I'll say, I think this would be a really helpful place to start with your child. And so in sessions, is it going to be okay if we focus on play and waiting to see what your little one does in play, and then responding to their signals? And typically, because families have really had that experience of, gosh, that was really like my little one did a lot more, or that was really helpful, or I hadn't thought about it like that before, it kind of hooks parents into, this is a valuable starting point. And I'm not having to sell it as a therapist that this is going to be great. It also gives me the opportunity as a therapist to talk through, what are you expecting from a therapy session? Because most of the time it's not that. Most of the time they're expecting that I will be doing session activities with the child myself. So by starting that in the initial appointment, I can have those conversations around, this might be quite, like, what are you expecting is always my first question. I don't make assumptions about that. And so this might be a bit different to what you're expecting. Is that okay? And why I'm going to start with this. And that's where I'll talk about when we waited, your child actually had a bit more time to organise their brain and their body and show us a play idea. And for your little one, potentially they're needing more time to get organised, and that's really hard in a busy environment at home. So let's practice that here, or let's see how he responds when we work on that. So that why piece of how it links to the parent's concerns for their child or the goals of coming to session is really important in that phase too, because otherwise it can feel like we're just doing, like child-led play or waiting, and I'm not sure why that's actually helpful. So our ability as a therapist to link that to the goal, or to say why this is where we're the starting point is hugely important. And then those sessions typically kind of are driven by how fast a little one goes in that phase. So for some children and families, things get on track again quite quickly. Parents, and I use video with families who are comfortable with video to help slow moments down, or get families, that same thing that I have of being on the outside looking in, video creates that opportunity for the parent. So the number of sessions in that phase 2 is kind of determined by individual families, and then when it starts to be like there's more attunement, or interactions are smoother or more resilient, we can often start to build in more targeted developmental guidance. So that phase 3. And from a physio perspective, I'm thinking about a little one I worked with where we did lots of strengthening of cue reading and responding to that first, and then we applied that to learning to pull to stand and how to support the parent to notice the little one's cues and support that. So we still do that as therapists. We just do it in a way that I guess is acknowledging the importance of parent-child interactions and also the child's cues as a foundation.
That's gorgeous. And phase 3 is called goal-oriented sessions, and a lot of people would be very familiar with that. But I love how you put this lovely link between all of it, just to center that conversation, just to make sure everyone's on the same page. And the way you've described it, it's not a threatening thing for a therapist to do, because it can be quite daunting to step in there and go, I'm going to talk about the relationship. And that's not what we're doing at all. We're just, it's Hanan. It reminds me of coaching and Hanan. And but with that relationship lens of really, our role is to try to strengthen that relationship, and that's how you get long-lasting, people don't have to be dependent on seeing you as a clinician. It's trying to get them out and being more independent. I really love it. Yeah.
And sometimes it's things that we might not perceive as therapists are big things, but the parent's taken something from the session and it may be a point you made or a specific thing about play and we may not even regard it if we're busy and we're, got these, we're in the goal-orientated sessions, but we've given them something and the parent takes that and all of a sudden they look at that child, differently and get different ideas of how they can interact at home, and that further, solidifies that attachment and then they're more confident to play. And I think, like you said, it's just liaising about, I guess, expectations.
Yeah.
And then those small wins, those pearls of wisdom that either as therapists we can give or the child may just present in a session that we can help kind of just grow between the child and parent is huge. So good. I really love how you highlight those things, not to ever be disregarded.
Yeah.
And I think the other thing you've just touched on is that kind of step-by-step approach. So if a little one has a goal, or if the family have a goal that they want their child to pull to stand, for example, and they're not yet showing us many motor initiations, the next step is that we want them to give us more, that we want them to initiate more. And why that's important is because that link, that builds strength and so that again, always the why piece to the parent. Then when we've got that, and that's through parent-child interactions, that next step, then we're going to the one after that. Because what I've noticed is that sometimes as therapists we might get stuck in only parent-child interactions or find it hard to explain, like that kind of step-by-step approach or the why piece. And so sometimes just a little visual around this is where they're up to, this is why initiations or parent-child interactions is a really helpful next step. And then from there we're moving on to this, which is in service of the goal that you have for your child.
Yeah. Just laying down that context really.
Amazing. Yeah. So incredible everything you've shared, Jacqui. I guess a big question is where to from here? So you've developed this model, you've obviously have a number of roles that you have, but what is your desires from here that you're going to follow up with?
So a lot of the work that I do is supporting therapists to shift more confidently into this way of working. And therapists acknowledge they're like, and lots of therapists have done, Hanen training or they're very well versed on aspects of this. But what therapists often say is that thing of, but how do I actually have that conversation or do the work? Yeah. So my next steps are evaluating some fidelity of this way of working, because I'm really interested in when we provide training around including a relationship focus, is it actually translated to practice, and what does that look like? Because it can sound easy in theory, but when you've got all of these other things in the background, it's not as simple as just using a relationship focus approach for most of us.
Yeah.
And then the other thing, I guess, is measuring outcomes for families.
Wonderful.
So when we do reorientate to working in this way, let's measure whether the outcomes that has for children and families, and is this something that leads to greater outcomes, so that we know that we are doing best practice as early childhood therapists.
Well, that is exciting. We'll be watching. We'll be definitely following your work, and then we'll be contacting you again as soon as we see things starting to get published too. But it's a lot of work, I know, but it's always so wonderful to know there's different researchers in different parts of the world that are really passionate about these areas that are important. And thank you for sharing that with us. But don't worry, we're not done yet. As you all know, we have our next very, very popular segment called Tell It to Ed. Ed is our producer. He doesn't have a background in child health, but he has been listening. He pushes buttons and faders, slides faders, and has been really keenly listening into this conversation. So Jacqui, I'll get you to summarize this area or what we've just spoken about in about 60 seconds or so. And Ed, you will have time for one question. Take it away, Jacqui.
Okay, so when we think about little ones with developmental difficulties, sometimes it's harder for them to give us their signals. And so for parents, it can then be much harder to know how to respond to those signals. And those signals are a foundation for all other aspects of development. So as therapists, it's really important that we build our skills and confidence in how to talk about that with families and how to include that as a core component of the services that we offer if we determine that that's something that would be helpful for this particular family that we're working with.
Beautiful. Lovely summary. Thank you, Jacqui. All right, over to you, Ed.
Oh, I have to say, I love this episode. I'm a broken record. I love all the episodes. But I love this parent-child relationship approach. And over the years of the pod, I guess the key components that I've seen in the research that's been presented in each episode is about that patient-initiated active engagement. And in light of that, I guess historically there have been lots of different approaches to these kind of, therapeutic interventions. And the one that perplexes me the most, I guess, is the idea that maybe for some of these like non-active engagement interventions, they take I think you said it well, a no pain, no gain approach. And the therapist, I guess, makes, very specific choices for their client or for the child. And to me, that seems to fly in direct opposition to the idea that this kind of regulations is really important. So I guess long-winded wise, what I'm asking is, are things like crying in therapeutic interventions, especially for children or young adults that have those kind of brain injuries or neurological conditions, is that okay? And really, is it the domain of the parent or the therapist, or is in general better education needed to show the value of placing greater value on parent-child relationships?
It's a really good question. And I think sometimes the mistake that can be made when people are thinking about, child-led or relationship-focused is that then we are totally guided by or dictated to by the child. And that's not what this is actually about. Like I said, there are times in, depending on what the need is of the child, where we need to take charge or put a limit in. And it's similar, I think, with when a little one is grizzling or starting to communicate that they don't like this. Can we read that cue around their level of distress with that and what the need is underneath that? Yeah. So for some children, it may be that we name, this is tricky, you don't like it. I'm here. We're going to and so potentially it might be when you're putting a little one in a standing frame and it feels new and uncertain. And by talking a little one through that, you're actually able to put them in the standing frame still, and they don't become completely dysregulated. They may grizzle about it, but with their parent, they're going, I know this is tricky. You're doing a great job. You're trying, or whatever the language is that is appropriate. They actually are able to stay calm enough that we continue with that activity versus the little one who becomes so distressed that they're arching backwards, and we make the decision that that's actually not in the best interests of the child or the parent to continue with that standing frame in that moment. And so the question that I often ask myself when I'm trying to make those decisions with a family is, what's the child learning right now, or what are they needing right now? And if a child has become so dysregulated that they're arching, then that's not going to be effective if I put them in that standing frame in that moment, because they're too far in that dysregulation and they're not learning anything except that that kind of dysregulation isn't being supported. Whereas the little one who's grizzling and an adult is still supporting them, they're learning that things can feel uncomfortable and we can still have a go. And so I think it's really it's dependent on the context and the situation. And And I find those questions really helpful for both parents and myself as a clinician around whether I persist or whether it's time to have a break and help that little one regulate first before we potentially try again. And what do we need to do differently next time if the little one's going to flip to dysregulation now whenever they see that standing frame, for example?
Yeah, sure.
Does that answer your question, Ed?
I think so. Yeah.
Thank you. Oh, it's a big one, isn't it? There's a lot to think about.
So much. I've taken so much from this, Jacqui, from how to tailor assessments to looking more at that parent-child relationship. And I love it how you say don't take tantrums personally. I will keep that one.
That'll resonate with many. No, absolutely wonderful. Thank you so much for your time today. We have really loved the conversation. Remember, to all of our listeners, please head to our website, researchworks.net, where we will put links to this paper. It was a great one. Please have a look at the model. We've spoken briefly about it today, but there's so much more into that paper too. And remember, there's a CPD form there that you can fill out as well if you want to keep this as part of a record of your PD requirements. But for now, we will say thank you and goodbye once again. Thank you again, Jacqui.
You're welcome. It was lovely to chat today.
Oh, so lovely. And to all of our listeners, we'll talk to you all again very soon. Take care. Bye.
Bye.
Bye.